Okay, here we go. Conditions affecting the chest and lower respiratory tract range from acute problems to chronic disorders. Respiratory disorders can affect airway or can affect the airway sacs or alveoli located at the end of the airways, or can interfere with gas exchange, which can lead to hypoxia and hypoxemia. Here are the learning objectives for this chapter. Please take a moment to review each one of these. Atelectasis again refers to the closure or collapse of alveoli and is often described in relation to chest x-ray findings and or clinical signs and symptoms of somebody having difficulty, right, to breathe. It is one of the most commonly encountered abnormalities that we see on chest x-rays. This is caused by the alveoli becoming deflated or filled with fluid. This condition is one of the most common complications for post-surgical patients. Many experiencing atelectasis will have a hard time breathing. This is exacerbated in patients with current lung disorders. So think about a patient who already has problems like a chronic bronchitis or an emphysema patient, right? And now on top of that, because of a different surgical procedure for some other related incident, they went under anesthesia and now they have atelectasis and actual lung tissue that's collapsing, right? Pieces of it. Signs and symptoms of patients with atelectasis include difficulty breathing, rapid shallow breaths, wheezing, coughing, pain, and of course tachycardia, right? Because your heart's trying to compensate. Although atelectasis can be asymptomatic until hypoxemia or pneumonia develops. So it's important that those are common signs and symptoms of somebody who's having atelectasis. But if it's only a small amount of alveoli that have collapsed, then the patient can be totally asymptomatic until, as a result of that partial lung alveoli collapse, it leads to hypoxemia in the body, right? Or it leads to fluid being trapped because of the collapsed alveoli, which fluid getting trapped causes pneumonia, then that develops, right? So it can be anywhere from asymptomatic to full-blown shortness of breath, dyspnea, all that. Again, general anesthesia can cause atelectasis because sedation changes the regular pattern of breathing for the patient, right? And so they have a more shallow breath. It's not a quality breath. And so as the exchange of lung gases changes, this can cause the air sacs to deflate, right? So you can see how they can collapse. Obstructive atelectasis is caused usually by a mucus plug, a foreign body that's held into the lungs, or maybe there's even a tumor that's affecting the airway, right? And then we have non-obstructive atelectasis that can be caused by car accidents, right? So trauma to the chest. Could be pleural effusion, which is when fluid builds up in the pleural lining of the lungs. Or it even could be caused by pneumonia, right? Some factors that increase the risk of atelectasis in our patients are old age, definitely number one. Any type of condition that makes it difficult to swallow. So you know your patients post-CVA where they have difficulty swallowing, right? That can lead to that. Confinement to bed. So if a patient's confined to bed and or we don't do turning and repositioning every 2 hours, right? That can definitely lead to atelectasis. Lung disease like COPD. Other lung diseases. Again, anybody going under surgery because of how the anesthesia works, right? To place us under. Anybody's breathing that's weakened due to spinal cord injuries or even neuromuscular disorders. There are some medications that cause breathing to slow down or become shallow. This can definitely lead to atelectasis. Smoking in and of itself can lead to partial lung collapse, right? Or alveoli collapse, so atelectasis. Pain or injury that makes it difficult for the patient to take deep breaths, like rib fractures, oh my gosh, are classic for patients having atelectasis. Again, how do we prevent it? So any patient that's at a higher risk, like all those I just listed, you're going to educate them to cough and deep breathe, right? Get the patient up. We're going to get them moving as soon as possible after surgery. We're going to show them how to use the incentive spirometer correctly, like we did in lab, right? So I'd make sure I know how to use that. And then we're going to help as often as we can to have them deep breathe and expand that full lung capacity, right? Every time you go in the room, have them use that incentive spirometer in front of you. During assessment of your patient, you find an increased work of breathing. Breath sounds may be decreased. You may hear crackles if fluid is building in those air sacs. Your pulse ox may indicate a lower or maybe a decreasing oxygen saturation. If these symptoms are present, then you will want to reach out to the prescriber and get an order for a chest x-ray, right? Because you want to try to determine what the diagnosis is, right? Nursing interventions include many of the following listed on this slide. Oxygen may be applied to increase O2 saturation levels that drop way too low. Now, we do know that COPD patients are not going to live in the 95 oxygenation range, right? It's just, it's impossible due to the amount of permanent lung tissue damage, right? But we are going to try to get the best oxygenation that we can without them retaining too much CO2, right? Having the patient turn, cough, and deep breathe are employed at regular intervals, right? The use of the incentive spirometer to expand the lung, complete lung capacity. We're gonna have them use inhaled medications, because sometimes those inhaled medications help to decrease inflammation and also increase their deep breathing, right? And also will help with getting rid of mucus, because we could use an expectorant or loosen secretions or all of that to help, make it easier to cough them up, right? We might also do chest physiotherapy, help break up and loosen those secretions as well to help them. It makes it easier to cough up. It's important that you realize that severe atelectasis can definitely lead to respiratory failure and kill your patient, right? So, and they also can lead to where the patient will need to be mechanically ventilated. So we need to stay on top of that so it doesn't get worse. It's also patients who have atelectasis has to have had thoracentesis, where they go in and remove fluid that could be causing the lung to collapse, right? We have had to do bronchoscopies before because of atelectasis. Again, bronchoscopy is a procedure done to open the airway due to an obstruction. For example, like a tumor, right? We do bronchoscopies for a lot of things. Sometimes we'll take samples through bronchoscopies too. You'll learn more about bronchoscopies in Block 2. Okay, pulmonary infections. So a lung infection can be caused by a virus, bacteria, fungus, or foreign substance sometimes, right? That'll trap bacteria in there. One of the most common types of lung infections is pneumonia. Patient becomes infected by breathing in the bacteria or virus after a nearby infected person sneezes or coughs. TB or tuberculosis is caused by a bacteria called Mycobacterium tuberculosis. The bacteria usually affects the lungs, but TB bacteria can attack any part of the body. Like I've seen it attack the kidneys, spine, and even the brain with a couple patients I had in the ICU. Not everyone infected with TB bacteria becomes sick. Next is valley fever. It's caused by a fungus that lives in the soil of dry areas in the southwest U.S. Of course, we know about that here in Arizona. People get valley fever by inhaling the spores that is in the soil. Influenza is a highly contagious respiratory illness caused by the influenza viruses. There are many. These viruses and illnesses can be mild to severe. And then, of course, older people and people with comorbidities are among the highest at risk populations for influenza or the flu. And the best way to prevent flu is for them to get vaccinated every year. Tuberculosis is an infectious disease that primarily affects the lung parenchyma. It also may be transmitted to other parts of the body again, like the meninges, kidneys, bones, lymph nodes, you name it. It can pass through the air between people because it's airborne, right? The spores are airborne. Therefore, we place these patients on airborne precautions where they're moved into a room that has their own ventilation system, right? Symptoms develop slowly and may vary from patient to patient. A bad cough that lasts for at least 3 weeks, chest pain, coughing, night sweats, low-grade fever, fatigue, and weight loss are typically the signs and symptoms we see. Might be blood-tinged sputum as well, right? Please see the tuberculosis risk factor chart in your book. It has some really good information about TB, as does the CDC, right? Center for Disease Control. They have like a good information in your book about preventing transmission of TB in the healthcare settings. It's in your med-surg book. Oh, that was fancy. Okay, lower respiratory tract disorders. So again, talking about pulmonary tuberculosis. And we have acid-fast bacillus. So the acid-fast bacillus is the definitive test to diagnose TB. Okay, we have other things that we can do to help either rule in or rule out different, lung infections, right? But if you genuinely want a definitive test, we have to do what's called the acid-fast bacillus test. Again, we know that it's spread airborne, right? And some risks that put patients at a higher risk to catch TB would be patients who abuse substances, immunocompromised patients who have diabetes, cancer, who are malnourished, and for some patients who live and work in an area where it's predominantly influx of tuberculin exposure. So it's imperative, again, that all of these individuals get their yearly immunizations to improve their outcomes. And because think about these things, when your body's already taxied with one problem, let's say a patient has TB, that automatically puts their immune system at risk for catching anything else, right? So I've had patients in the ICU who literally had TB and then ended up getting flu on top of that, right? So that's the last thing we want to do. So we're going to encourage them to get all of their immunizations. Know that TB can also lead to fibrosis and calcification of the lungs, and there are very resistant strains out there of TB. One that is predominantly very difficult to manage. So be aware of that and know that the provider has to get creative sometimes when we're treating TB, right? So again, signs and symptoms of patients who come down with TB include malaise, pleuritic pain, fatigue. They're going to have fever, night sweats. They could have chills. But most will have a persistent cough that is 3 weeks or longer. It could be productive. It could be non-productive, right? If it's productive, usually the sputum is going to be a green or yellowish color. But remember that it's not uncommon to have like blood in the sputum. So you might have a serosanguinous sputum, blood tinged sputum, right? And then a big one too for them is that they have unintentional weight loss and loss of appetite. So those are big ones, right? I would make a flashcard on this information, right? Because you're definitely going to want to know TB is going to be hit hard on NCLEX as well. HESI's going to test questions, and of course we'll have questions as well, right? There are two kinds of tests, again, used to detect TB bacteria in the body. We have the tuberculin skin test, and then we have TB blood tests. So a positive tuberculin skin test only tells that a person has been exposed to somebody who had TB, right, at some point. So it doesn't tell us whether or not the patient actually has TB itself, or have they just been exposed to it, right? It doesn't decipher between those two. Other tests that we use after this would be a doctor may order a chest x-ray, maybe a sputum sample, all of that, right? So again, the PPD, or the mannitol tuberculin test, is one method of determining whether a person has ever been infected or, potentially exposed, is a better way to say that, to TB. And then again, we inject 0.1 mil of tuberculin purified protein under the skin, right? And again, the injection should be made with a tuberculin needle, and you want to use the bevel up and about a 5 to 15 degree angle. And the skin test reaction is read between 48 and 72 hours later. An induration of 5 or more millimeters is considered positive in an immunocompromised person, like somebody with HIV. But anyone else, like a healthy individual, would need an induration of 10 or more to be considered positive. Again, a positive test result doesn't mean the patient has an active form of TB, but just simply means that the patient was exposed to TB in the past at some point in their life, right? Next, after that, if you got a positive PPD test, usually the next step could be a chest x-ray. And chest x-rays have poor specificity, just FYI, when it comes to TB. So if they get a chest x-ray and the healthcare worker sees something on the lung, it can be a lot of other things that's not necessarily TB. Therefore, a chest x-ray are usually an indication of whether or not a person might be exposed to it, but it definitely is not a definitive diagnosis with a chest x-ray, right? The acid-fast bacillus, like I mentioned a few minutes ago, is the confirmation of TB disease. That is what will determine whether or not the patient does in fact have TB. Okay, here's a great slide. I would recommend that you pause it and read through it. It gives you some good ideas about TB and some risk factors and populations to be on the lookout for. This is really good. This is from the CDC about preventing transmission of TB. So I'd pause it and just look through it. So pulmonary TB assessments and findings. Okay, we assess and screen for TB while obtaining a health history. We ask questions regarding the typical symptoms like cough that doesn't go away, night sweats, have you been out of the country within the last 30 days, all of those kinds of things. Have you lost weight? Has your appetite decreased? Like, just things that might lead us to that. We test for TB using the tuberculin skin test. And there's also a quantiferin blood test that we can do, right? I think that's the one you guys did for nursing school. If one of these were to come back positive, the physician generally will order a chest x-ray and a sputum culture to confirm if the TB is active or is it in a dormant state, right? There are only, let's see. And if it's a dormant form, then they're not contagious. But if it's an active form, clearly they have to be treated, right? So pulmonary TB is treated primarily with anti-TB meds for 6 to 12 months. And usually patients need to take, multiple meds. It's a prolonged treatment. The prolonged treatment is necessary to ensure eradication of the organism and to prevent relapse, right? And the continuing and increasing resistance of tuberculosis to the TB medications is a huge worldwide concern right now and challenge in TB therapy. Several types of drug-resistant microorganisms have, within the last 5 years, have come around, and it is considered, it's something the provider takes very seriously when planning effective therapy, right? Because we have to eradicate it. TB could literally obliterate an entire population, so that's why it is one of the few things that the government will mandate that patients have to be treated for, because it's communicable, right? And again, it can take out an entire population. So it is a condition that we can make our patients take meds for. Okay, what else do I want to tell you about this? That's very important to know. So it's very important, obviously, that, again, they're going to take multiple med regimens, 6 to 12 or even longer months. Could be up to 4 or 5 medications I've had patients on before. They need to ensure they complete all of the therapy. And your book does have some pretty good first-line anti-tuberculin meds that I would look at, just so you have an idea. And we're going to talk about the ones you need to know for block 1, 2 in class. Again, treatment to the tuberculin is guided by the sputum sample, right, and sensitivity testing that occurs, so that we can see whether or not the patient, is susceptible to the meds. Now, patients are typically treated with INH and or rifampin. Those are 2 that we need to know for block 1. And usually, again, 3 to 5 drugs are identified as appropriate and are typically prescribed. Nursing management of TB. So active tuberculosis can produce mucus that can interfere with adequate gas exchange. Nursing interventions include encouraging increased fluid intake to help, again, loosen the secretions so that they're easier to get out of the body, and to keep those airways clear, right? Adherence to the prescribed treatment regimen is key in treating and controlling the spread of the infection, right? Again, the medication regimen is complex, making understanding of the medications, the schedules, when to take them, the side effects that they can anticipate seeing or potentially seeing. All of that is going to take time. So the nurse needs to make sure that we educate our patients when we are giving them each of the meds. You're going to educate them thoroughly about it, and make sure that they're able to teach back all of those directions. So just have them repeat it back to you as if they were educating you on taking the TB meds. As nurses, it's our focus to educate patients on the need to complete medication therapy, especially with TB, right? Because TB medication therapy is the best way to reduce the risk of transmission. And failure to stick to the regimen increases the risk of resistance, right? Because when you take an anti-TB med and you knock back that virus and then you stop taking it, all you're doing is teaching that virus how to overcome that medication. It gets stronger and stronger, right? So it builds up a resistance, basically. So it makes it harder for that patient to recover from that, right? Again, weight loss, anorexia, and malnutrition are common in those fighting tuberculosis, because excessive coughing from sputum production creates fatigue, and the willingness to eat is altered, right? Again, we go back to the whole point that it's just more exhausting to try to eat than it is worth to do it. So they just don't put the effort in, and it's important that we teach them how to drink more water, thin those secretions out, take extra meds to help with all those things, right? The fatigue and malaise also can cause a person to not regularly, actively, do things too, right? So they may be more sedentary, which can lead to additional problems. So it's important that we discuss that with them as well. Preventing transmission is combined with proper treatment adherence and proper hygiene practices is also important conversations to have. So it's important, as far as the hygiene, it's important to teach patients about proper oral care, about covering their mouth and nose when coughing. So instead of coughing in their hands, coughing in the crook of their arm, right? By the elbow inside is a great way to cough into their arm right there, right? Or they could, if they have tissues, that's another good thing, is to cough into the tissues, throw that away, but then do good hand hygiene after, right? TB is a disease that must be reported to the health department so that those that have been possibly exposed to this patient can be screened, notified, and seek treatment if necessary. Okay, antitubular meds. There are 5 first-line medications. So again, medications are the cornerstone of tuberculosis treatment. But treating TB takes much longer than treating other types of bacterial infections. For active tuberculosis, you must take antibiotics for at least 6 to 9 months, potentially longer. The exact drugs and length of treatment really depends on the patient's age, their overall health status, possible drug resistance, and infections located throughout their body. Active tuberculosis, particularly if it's a drug-resistant strain, will require several drugs at once. The most common medications used to treat tuberculosis include isoniazid, isoniazid, rifampin, rifampin, etambutol, etambutol, and pyrazinamide, pyrazinamide. If a patient has drug resistance TB, combination of antibiotics called fluoroquinolones, fluoroquinolones, and injectable meds like Capistat are generally used for 20 to 30 months. Yes, I said that right, 20 to 30 months. Again, that's only for the really resistant strains, right? Okay, what else do I want to tell you? Some medication side effects. So it's important to realize serious side effects of TB drugs aren't common, but they can be dangerous when they do occur. All tuberculosis medications can be highly toxic to a patient's liver. When patients take these meds, we're going to educate them to call their doctors immediately if they experience any of the following: nausea and or vomiting, loss of appetite. A big one is yellowing of the skin. So when they get that jaundice color, that's not good, right? Because it's the liver that's struggling. If they have dark, concentrated urine, that's going to be the kidneys or the renal system struggling. A fever that lasts 3 or more days but has no obvious cause, that's not good. And again, it's important that we educate them that completing the treatment regimen is essential. While after a few weeks, the patient may not be contagious, and they will start to feel better. So some of them are tempted to stop taking their TB meds, but it's important that we tell them this and tell them that it's crucial they finish the full course of the therapy and take the medications exactly as the provider has prescribed, because stopping the treatment too soon or skipping doses will allow the bacteria to still be alive and to become resistant to those drugs, leading to TB a strain of TB that's much more dangerous and more difficult to treat, right? And so you have to literally have that conversation with your patient so they get how serious it is, right? And say to your patient, it's okay to say, yes, treatment for tuberculosis is complicated and a lengthy process, but the good thing is that we can treat it and eradicate it from you, and you can live a healthy life after, right? Because the only way to cure the disease is to stick with your treatment, right? You may find it helpful to have your medication given by a nurse or other healthcare professionals so that you don't have to remember to take it on your own. We can set that up, right? That's something that a conversation that's had between you as the nurse and the patient. And then again, please notice that all of these meds are hepatotoxic, right? So we are definitely going to monitor the ALT and the AST. Those are your liver enzymes. So we're going to be doing lab values on those frequently when the patient is on these meds. Okay, here are the meds. You don't need to know the dosage, but you should know the name of the med, and literally like considerations. What do we need to know about them, right? And then, like rifampin, it turns our normal body secretions orange. It's a side effect. It happens. It's not a big deal. But if we don't tell a patient that and they sweat orange color, they're going to think their kidney or liver is dying, right? So it's important we tell them about that. So again, don't memorize the dosage on this screen, but you should have an understanding of the things it can cause, each of these meds. And then, again, we'll talk more about it in class when we do our case studies. Okay, so let me see. We talked about that. We talked about those. So there's the spellings. Isoniazid, rifampin, and etambutol, and pyrazimide are the 4 drugs for block 1. Let's see. Okay, here's another one. Avoid antacids, alcohol, and sunlight when you're on these meds. That's important. There are those meds that are the serious side effects. Okay. Medication regimen, again, is a long-term and can be grueling combination therapy. Prophylactic therapy may even occur after the full regimen, too. It's important that patients continue to take their medications as prescribed. Let's see. It's also important that they do what's called collaborative care. So during this time, they're going to need to get bed rest. They're going to need, especially in the beginning. I don't say bed rest for a year, but the first 3 weeks, they're definitely going to need bed rest. They're going to, they're going to be exhausted. Their body's fighting a pretty significant infection. And this is not a time the patient needs to work out and should not work out for the first 3 weeks. They're going to be getting rest, hydrating, doing all the things they need to do, right? They need to stay isolated for the first 3 weeks. They need to know that during this 3 weeks where they're taking these combo meds, they are contagious. Their spores are airborne, and they need to have their own ventilation, so be alone basically in their home, or probably more realistic, have them wear an N95 mask, or have the family and friends fitted for an N95 mask when visiting, something along those lines, right? Because I don't expect the patient to wear an N95 mask all the time, right? Oh, and nutrition. So eating veggies, fruit, minerals, taking supplemental vitamins, especially Bs, B12, B6, B3, consuming high protein, going to be really important. Because one of the meds, the INH, could potentially, decrease the levels. So we are going to assess our patient for the expected side effects, and that's fatigue and anorexia and loss of appetite and fever, night sweats, right? We're going to look for color, consistency, and the total amount of sputum. Hopefully that will improve as they take their meds, right? So that's things we're going to be looking for. We're going to listen to the lungs, of course, really well and document that thoroughly. Documenting any adventitious or extra lung sounds, right? We're going to, some of the nursing diagnoses are listed here. Again, we're going to educate them to provide for frequent rest periods, encourage coughing and deep breathing. We're going to teach them the importance, again, of, I know I've said it a million times, but honestly, sticking to their medical regimen, the schedule, not skipping doses, and the importance of follow-up with their doctor. They got to stay connected to the physician's office really closely. All the preventions on how to avoid spreading the infection. We're going to teach about hemorrhaging and hemoptysis. We're going to teach them what's an expected amount of blood that's okay to cough up, which is minimal. And then we're going to, and teach them the signs and symptoms of, if it's more than minimal, what that looks like. Okay, so next we're moving on to pneumonia. Pneumonia is a lung infection that causes inflammation, and it's typically caused by microorganisms such as bacteria, fungi, and viruses. Pneumonia can be classified into 4 different types. We have community-acquired pneumonia, CAP, hospital-acquired pneumonia, HAP, healthcare-associated pneumonia, CHCAP, and what we call VAP, ventilated-associated pneumonia. Make sure to pause the video and review these pneumonias and understandings of their differences. They're listed thoroughly in your book. Clinical manifestations. Again, in your med-surg book, you have commonly encountered pneumonias that list many clinical features of each. They're summarized in there. The most common clinical manifestations for pneumonias are chills, fever, but not always a fever, shortness of breath, pleuritic chest pain, and myalgia. Depending on the severity and the amount of fluid in the lungs, you may hear crackles, generally in the bases of the lungs. Inflammation may be heard as wheezing. Remember, we talked about wheezing in the other video about how it's restriction of the pathways, right? So you're going to hear that inflammation and restriction as wheezes. If cough is productive, the sputum may take on a purulent tinge, and in some severe cases of pneumonia, it could be blood tinged. Okay, assessment. So assessment for pneumonias are the patient's current medical and social history. Going to do a physical exam, chest x-ray. We're going to look at blood cultures to look for those microorganisms that could be causing the infection. We're going to do a sputum culture. Again, make sure you actually get sputum when they cough and spit it out and not just their saliva, right? So get a good sputum sample. We might do a bronchoscopy. Again, remember that's that invasive procedure where the doctor goes down with the scope down into the lungs to see any abnormalities that might be occurring in that area, right? Medical management. Okay, treatment of pneumonia includes antibiotics if it's bacterial. Remember, antibiotics do not treat viral infections, and many times respiratory infections are viral, right? And we treat those with antivirals in some cases. Other times it just needs to run its course, right? It really depends on the virus and when we catch it, right? When they seek treatment, I should say. Supportive treatment includes increasing fluids to assist again with loosening secretions, as well as aiding in expectorating that mucus. We will also give antitussives, decongestants, antihistamines, all of those things, right, to help reduce the mucus production and also help relieve and reduce symptoms. We could use antipyretics to help reduce fevers. There's all kinds of stuff we can do. In addition to the initial head to toe assessments of the patients with pneumonia, we're going to do a more focused assessment of secretions. It's important to note the amount, the color, the consistency, if there's an odor to them, because there are sometimes, how frequent the patient coughs, if the cough is productive or not. Note if the patient is able to clear their own secretions on their own, and if not, how much trouble are they having, right? Auscultate the lung sounds, note any abnormal sounds and also note in which area of the lung fields you are hearing those sounds. If the patient is having difficulty breathing, watch their oxygenation saturation rate and apply oxygen as needed to keep their saturations up. These focused assessments will be more frequent in your patients. Oh my gosh, I got the hiccups. I'm so sorry. These respiratory focus assessments will be more frequent in your patients with lung infections, as changes could happen rapidly, and you will want to stay on top of those changes and watch for any changes that you can escalate to your provider. Okay, here's some nursing diagnoses. This slide lists some NANDA nursing diagnoses that may be associated with patients experiencing lung infections. Pause the video and take notes. Nursing planning. So our plan or goals for the patient with a lung infection will include improving and keeping a clear airway with good oxygen saturation. We want to improve their activity through a decrease in fatigue. We want to maintain proper hydration, maintain proper nutrition that will help support healing. We want to teach our patients about preventive measures as well as how to heal without complications or without worsening the infection, right? So we're going to educate them on all that. Prevention. Okay, so take a look at your med-surg book for a summary of preventive measures for pneumonia. One of these preventive measures is the pneumonia vaccination or the pneumococcal vaccination. This vaccine is given every 5 years. I want to say it's given once, and then 5 years later, if you're elderly, you could get a second dose. And then I think evidence-based after the second, 5th year dose is that it's no longer beneficial. But that's always changing too, right? So we will go off what's best evidence-based practice at that time. But again, it's important that we, as the nurse, screen them to ensure that they've had or at least been talked about the pneumococcal vaccine to keep them safe, right? Okay, again, take a look in your med-surg book to see a summary of risk factors and preventive measures for pneumonia. Underlying diseases can increase the risk for pneumonia, such as heart failure, COPD, diabetes, AIDS, alcoholism, cystic fibrosis. Influenza is a leading factor to the development of pneumonia. So all of these things, right? I would pause this video and read through this. This is a really good slide. As is this one. Pause the video. Take really good notes because some of this stuff is on HESI. We're definitely going to have some of it on our test as well. Okay, nursing interventions. So, interventions for our patients with pneumonia are to apply oxygen, preferably with humidification, to help maintain oxygen saturation levels. Depending on the severity of the patient's symptoms, you may want to consider monitoring the oxygenation saturation continuously until they get stable, right? We want to make sure that their tissues are getting enough oxygen. Coughing techniques include, we need to teach them about coughing techniques. We need to teach them about staying hydrated so that we can reduce the viscosity of the mucus and make it easier to cough up. We want to talk about the use of incentive spirometers to help expand that chest and get the full quality breaths and the most oxygen we can into the system, right? And it also helps clear out secretions. Chest physiotherapy, we're going to discuss this on how that's used to break up secretions that settle in the bases of the lungs, right? It helps with aiding and expectoring those that mucus. Yes, okay. Expected outcomes. So this slide highlights some goals for a patient who has pneumonia. So obviously protecting the airway is priority, as is adequate oxygenation of the tissues. It can be the most difficult when secretions are accumulating in the lungs, right? It can be really difficult to get adequate oxygen all out to the entire body. So we got to teach the importance of the hydration as well as rest for conservation of energy, because both of those will improve oxygenation as well as reduce the shortness of breath and provide a better opportunity for the patient, to take in oral hydration and oral nutrition too. Because when patients get tired and short of breath, they're not going to want to eat or drink. So by teaching them these two things, it'll improve both of those outcomes. Okay, I can't stress how important this slide is. So pause the video and make note cards of this information. It will definitely be on HESI, and it's either on our test or on the final, but it's going to be on there for sure. Okay, valley fever is the next topic we're going to talk about. So valley fever, also called koikodymycosis, is an infection caused by the fungus Coicidioides. Oh my goodness, I'm slaughtering all these words today. My apologies. This fungus is known to live in the soil, again, in the southern United States, as well as parts of Mexico and then Central America and South America too. Fungus has also recently been found in Washington, central Washington. So it's starting to get around, right? So people can get valley fever by breathing in these microscopic fungal spores from the air. Almost most people who breathe in the spores don't really get sick though. So again, many patients will breathe them in, these spores, and never get sick. But usually the people who get sick with valley fever will get better on their own within weeks to months also, right? But some people will need antifungal medication. The fungus lives in the soil and can be transmitted through inhalation of the dust. Anybody who lives or travels around Arizona, California, Nevada, New Mexico, Texas, Utah, those kinds of parts, or Mexico, the country, Central or South America, can get valley fever, right? It can affect any person at any age, but as with most things, as we age, the percentage of patients who get it are higher, right? So anybody over the age of 60, it's common in, right? Certain groups of people may be at a higher risk. That's what I'm trying to say. It's a higher risk for developing valley fever. Not only that, but severe forms of valley fever, right? Because as we age, we know every organ is deteriorated over time, right? And our ability to respond to infections is minimized as we age, right? Or if you think about other individuals who would be at a higher risk, as well as complications from treatments, would be patients who are immunocompromised. So cancer patients, patients who take steroids like prednisone, right? That reduces the body's natural immune response. So that puts them at a higher risk. Patients who have organ transplants, AIDS, HIV patients, all of those immunocompromised patients, rheumatoid arthritis patients, those kinds of patients, right? Some people are more susceptible when they travel, right? So got to be careful of that. Let's see. Again, though, many people who are exposed to the fungus Coccodioides never have symptoms. Other people may have symptoms that go away on their own after a couple weeks, right? Or a couple months. But if symptoms last longer for more than a week, we want to encourage patients to reach out to their healthcare providers, right? And we're talking symptoms like fatigue, cough, fever, shortness of breath, oh my gosh, headaches. Could include night sweats, muscle aches and joint pain. Oh my goodness, a rash that'll appear randomly on the upper body or the legs. And In some extreme rare cases, the fungal spores can enter the skin through a cut wound and actually cause a skin infection. So that's a heads up we want to give a few patients, especially if they come in, and they have an infection in the skin. It could end up being from the coccidioides fungus, right? Let me see. Symptoms of valley fever may appear between 1 to 3 weeks after the person breathes in those fungal spores. There are sometimes patients will get a rash due to the valley fever. That's erythema nodosum. Symptoms of valley fever usually last for anywhere from a few weeks to a few months. However, some patients have symptoms that last much longer than this, right? Especially if the infection becomes severe. So in approximately 5 to 10% of people who get valley fever, those patients will develop long-term severe problems with their lungs. And then a really small percent, I used to take care of patients in the ICU, about less than 1%, you'll actually have valley fever spread from their lungs I had a patient in the ICU who it spread to their spinal cord and brain, of course, and then they died. But that's rare, less than 1%. So how is it treated? How is valley fever treated? For many people, the symptoms of valley fever, again, will go away on their own within a few months without treatment. Healthcare providers choose sometimes to prescribe antifungal medications for some people to try to reduce the severity of symptoms or prevent the infection from getting worse, right? And it really depends on the patient. You're immunocompromised, you can bet they're probably going to be treated, right? Antifungal medication is typically given to people who, again, are at higher risk for developing severe valley fever. And the treatment is usually 3 to 6 months of fluconazole or another type of antifungal medication, but fluconazole is the one you would need to know for block 1. There are no over-the-counter meds to treat valley fever. If a patient has valley fever, they definitely need to talk to their provider to see whether or not they need treatment. The medical provider who diagnoses the valley fever may suggest going to somebody who specializes in valley fever, especially if it's one of those patients who could end up with a severe form that could kill them, right? And then if patients have this severe form, clearly they're going to be on antifungal treatment and probably need to stay in the hospital to be treated. Because for these types of infections, it can be really, really severe, right? So we'll keep them in the hospital until they're stable and then send them home, and they can expect to be on these meds for longer than 6 months if it's a severe form. Valley fever that develops into meningitis is fatal if it's not treated. So lifelong antifungal treatment is necessary for those cases, right? It's in the meninges. So there are a very small percentage of patients who have to be on the antifungals for life if it goes into the meninges. Okay, so a lot of patients will ask, if I have valley fever, should I stay home? Valley fever isn't contagious, so they don't need to stay at home to avoid spreading the infection to other people. However, the healthcare provider may recommend that the patient stays at home to help the body fight off the infection. Now, this, of course, is in the initial stages, right? Does valley fever have any long-term effects? That's another thing patients ask. And so most people who have valley fever will make a full recovery, right? So that's almost everyone. There is a small percentage of people who develop long-term lung infections that can take several years to get better. And in some very, very severe cases, which are very few, the nervous system can be affected and there may be long-term damage. But again, that's very, very rare. Okay, this is another really great slide talking about the flu or influenza and the signs and symptoms that a patient will see. Pause the video, make note cards, right? Again, these are signs and symptoms on the right. And again, influenza is a virus, right? And affects the lungs, nose, and throat. And then it talks about, the fatigue, tachypnea, tachycardia, severe muscle aches, high fever, all of the things, weakness, diarrhea, chills, right? Things that you will experience. So again, pause the video and add these to your note cards, right? Diagnostic testing for influenza includes a viral nasopharyngeal swab. And then, of course, we could treat it with antivirals, right, depending upon which virus it is and how quickly did the patient come in from that virus, right? Rest, fluids, anti-inflammatories, possible cough medications. But again, if the patient is going to take an antiviral, it needs to be within the first 48 hours of onset of symptoms of the virus, or it really isn't in time. And just so you know, taking an antiviral doesn't get rid of the virus. It just shortens the infection by about a day and a half to 2 days. That's all it really does. So again, treatment, rest fluids, anti-inflammatories, cough medications, antivirals. If influenza is a true case of, with the flu, it's a true case of symptom management. That's what we're looking to do, is manage the symptoms and provide as much relief to our patient as possible, right? There are 2 antiviral medications that can be used. We have Tamiflu and we have Zoxflu. Tamiflu is the one for block 1, but again, it must be started within 48 hours of onset of symptoms, and they don't get rid of it. They only decrease the length of the infection by about a day and a half to 2 days. Preventive things we can do to have patients do that can prevent spread of influenza include hand washing. Number 1 most important thing, hand washing, soap and water, 20 seconds or longer, covering their mouth with their elbow when they cough or sneeze. We call that coughing and sneezing etiquette. They want to avoid crowded areas, especially in the winter. Get their annual flu vaccinations, and please stay home if you're sick. That's what we're going to tell our patients, right? Here are some nursing diagnoses for, I would pause the video, make note cards. Aspiration refers to the pulmonary consequences resulting from entry of endogenous or exogenous substances. So that's things that should not be there, right? Or things that are there, like saliva. So when we inhale those into the lower airway, this can lead to aspiration pneumonia, right? The upper airway prevents potential infection particles from reaching the sterile lower respiratory tract. Aspiration is inhalation, again, of foreign material, could be oropharyngeal, it could be stomach contents. There's so many things it could be, right? And we're inhaling them into the lungs. This puts the patient at risk for pneumonia. Clinically, the patient may present with tachycardia, dyspnea, central cyanosis, hypertension, hypotension, and it could potentially kill them, okay? Again, your med surg book has some really good risk factors for aspiration. I would pause the video and go take a look at it. Here's another section here that talks about risk factors for aspiration. Clearly, if there's a brain injury, right? If we have a CVA or the patient were to hit their head, in an accident, things like that. Seizures, obviously, many times when at the end of a seizure, a patient will vomit, right? And so it's important that we turn those patients on their side. Any type of decrease in LOC, right? Whether it's alcohol intoxication or opioid overdose or any of that kind of thing, right? Or even general anesthesia, coming out of anesthesia, right? Your patient doesn't have, you got to make sure coming out of anesthesia that your patient has the swallow reflex fully intact before we give them ice chips or anything else, right? Patients laying flat in their bed and trying to eat or drink or take meds. That is not good. Raise that head of the bed. Swallowing disorders. Oh, there's so many. And cardiac arrest. What can we do to prevent aspiration? There are many things we can do. Raise the head of the bed again, right? 45 degree, well, 30 or higher. So that's semi-Fowler's, 30 to 45 or higher, right? Clearly, when a patient's taking sedatives, realize that swallowing is going to be compromised, and only using them when we need to. Before initiating tube feedings, confirm that the PEG tube is, I'm sorry, the NG tube is in the right location, so we're not putting in medications or food into the lungs and not in the stomach, and also making sure that the head of the bed is lifted at least 30 degrees, potentially higher. Making sure we're checking for residual, right? Because that's not good if they're not digesting their feeds. Definitely getting a swallow eval before we start putting things in there, and yeah, the rest of that's good. Aspiration prevention, again, aspiration includes keeping the head of the bed elevated 30 degrees. Let's see, at least half an hour after feeds. Always keeping it at 30 degrees or higher when continual feeds are running. And checking placement before we put anything through the NG tubes and JG tubes. We want to make sure a speech therapist has already done the swallow eval and knows whether or not they have difficulty. And if they do, making sure that the liquids are thickened to the level that the patient can tolerate and safely swallow, right? So we're going to thicken the liquids. We're going to puree the foods. We're going to do all the things to help them. Oh, man. My apologies on that. I flung the thing out. My apologies. Okay. Next on the list is pulmonary emboli. We're almost done with this video. Pulmonary embolism refers to the obstruction of the pulmonary artery or one of its branches by a thrombus that originates somewhere in the venous system or in the right side of the heart. Pulmonary embolisms can be associated with trauma, surgery. In surgery, I'm talking orthopedic or abdominal surgery or pelvic surgery or gynecological surgery, right? It can be, pulmonary embolisms can be from pregnancies, heart failure, older than 50 years of age. It could be hypercoagulability of patients. It could be due to prolonged immobility. It could be caused by a million things, right? And when we talk about pulmonary embolisms, there are different types of emboli, right? Not just blood, right? But we have air, we have fat emboli, we have amniotic fluid emboli, and we have septic, which is from a bacterial invasion of the thrombus, right? And gas exchange is impaired or absent entirely in the area where the thrombus is located. In addition, various substances are released from the clot and surrounding area that causes regional blood vessels and bronchioles to constrict. Symptoms depend on the size of the thrombus and the area of the pulmonary artery that's occluded by the thrombus, right? So if it's a small thrombus and it goes to an area of the lung that, it doesn't include a main branch of the lung, then those symptoms may be non-specific, right? Patients can actually have one and not know it. However, that's not the norm, right? Dyspnea is the most frequent symptom. So again, dyspnea is the most frequent symptom, good Lord. The duration and intensity of dyspnea depends on the extent of the embolization of the PE, right? Chest pain is common and is usually sudden and pleuritic in nature. So this is patients who have pulmonary embolisms, right? They're fine 1 minute and then the next they're not. They're having severe chest pain. They're having difficulty breathing, pain, right? All of these things, right? It could be substernal pain. It could mimic a heart attack, literally. Other symptoms would include, if you're unable to breathe, all of a sudden you would get anxious, right? Anxiety, fear. Your heart's going to work overtime. Tachycardic. Tachypnic, you're going to be apprehensive. You could be coughing. You're definitely going to be diaphoretic, right? You may have some hemoptysis, and the patient may pass out on you or have a syncope episode, right? The most frequent sign, though, is tachypnea, which is a very rapid respiratory rate, right? Death from acute pulmonary embolism commonly occurs within 1 hour after the onset of symptoms. Therefore, early recognition and diagnoses is priority. Cannot stress that enough. Early recognition and intervention is priority. Prevention of thrombi and treating. So, initial diagnostic workup may include chest x-ray, EKG, pulse oximetry, arterial blood gas analysis, right? PEs are often a medical emergency. They are definitely considered a medical emergency. Emergency management is of primary concern, right? Patients need to be in a hospital and taken care of. A CT angiography can be performed to break up or remove the clot, and the patient will be started on anticoagulation therapy, really depending on the type of pulmonary embolism, right? And depending on the risk of the patient to have another pulmonary embolism, they may be put on blood thinners for quite a while. And some patients take them for life, depending upon the condition they have, right? Preventing thrombus formation is a major nursing responsibility. The nurse encourages early ambulation and active leg exercises to prevent venous stasis in patients who have been prescribed bed rest. The nurse will instruct the patient to move the legs in a pumping exercise so that the leg muscles can help increase the amount of venous flow that's occurring. The nurse also advises the patient not to sit or lie in bed for prolonged periods, right? Also, we try to remind them not to cross their legs, not to wear constrictive clothing, those kinds of things, because we want the blood flowing pretty good, right? Intermittent sequential devices or SCDs will be put on if they're on bed rest for sure, right? And anti-embolism stockings may be ordered for the patient to wear while they're in bed. Help push the blood back up to the heart. Last slide, chest trauma. So blunt thoracic injuries are directly responsible for about 25% of all trauma deaths, right? Types of blunt chest trauma include dislocations, chest wall fractures, barotraumas, which are the diaphragmatic injuries. It might be injuries to the pleura, the lungs, but chest wall injuries are often life-threatening and result of one or more of the following pathological states. So it results in hypoxemia from disruption of the airway, could result in injury to the lung parenchyma, the rib cage, respiratory musculature. Patients might end up with massive hemorrhaging, collapsed lungs, which pneumothorax, right? Collapsed lungs. Hypovolemia from massive fluid losses, right? It could even result in cardiac rupture or hemothoraxes. Could lead to cardiac failure, cardiac tamponade, cardiac contusions, could lead to a flailed chest, especially if they hit the steering wheel. That's one of the number one things we see, a flailed chest, is a complication of a blunt chest trauma from hitting the steering wheel. Let's see. It could be a combination of ribs and sternum fractures. The chest wall will lose its stability, causing respiratory impairment, and will lead to severe respiratory distress. Pneumothorax occurs when the pleura breaches the pleural space. It's exposed to the positive atmospheric pressure. Remember, we talked about that earlier on. When that negative pressure is disturbed, you get your lung will collapse, right? Because you know that the lung stays inflated in the chest cavity from that negative pressure, right? That's what keeps the lung inflated, and when that's disturbed, you're going to have you're going to have it collapse on you, and you're going to get a pneumothorax. And then we'll have to put a chest tube in, and that chest tube will collect air and fluid, and it will reestablish the negative pressure, and your air will reinflate. Your lung will reinflate. Okay, and then finally, the last thing I want to mention is a hemothorax will happen when either the pleura is breached by fluid entering the pleural space. That will literally cause the lung to collapse. All right, this is the end of this chapter.